to my channel. Today I'm going to discuss a very important topics, some important topics in fact from the obstetric units of Toronto Notes 2025 edition. And the first topic I am covering today is placenta previa. Okay, let's start. What is the definition of placenta previa? Placenta previa is defined as the placenta implanted in the lower segment of the uterus that is covering the internal cervical os, either fully or partially. So basically, the placenta that is lying in the lower segment of the uterus and is covering the cervical os, either fully, either partially, whatever is the case, that is known as placenta previa. Placental location described in relationship to the internal os as millimeter away or millimeter of overlap. It's a simple in simple language it means that the placenta is covering the cervical os, internal os, and is either a few is millimeters away from the os or is a millimeter of overlap of the os. Okay, so what are the clinical features? The pregnant female, when she has placenta previa, she presents with painless bright red vaginal bleeding. Always remember, placenta previa is painless. Okay, placenta previa is always painless. Okay, and is a bright red vaginal bleeding that occurs and comes again and again, recurrent. Okay, it does not stop once it appears, on and off it comes and goes again and again, recurrent, may be minimal and cease spontaneously but can become catastrophic. Okay, so it can vary in different females. Sometimes it can be very small, scarce, scanty bleeding, little bit bleeding, minimal bleeding. Sometimes it ceases all of a sudden, and sometimes it can become heavy and regular and catastrophic for the female. So the mean onset of bleeding is guessed to be is supposed to be 30 weeks. Okay, by 30 weeks is the mean age of gestation, but the onset depends upon the degree of previa. Okay, now the physical examination. So we have to do the physical examination of the female, very important, but always remember, do not perform digital vaginal examination until placenta previa is ruled out. Very important. So if the patient comes to you with a suspicion of placenta previa, are we supposed to do the vaginal examination? No, a big no. Do not perform vaginal examination until the placenta previa has been ruled out by ultrasound. So ultrasound can rule out placenta previa, and we are not supposed to do the vaginal examination if there is a suspicion of placenta previa. Speculum and transvaginal probe are safe. So speculum examination and so basically digital examination is not safe, but the speculum examination and the transvaginal, we put a probe inside the vagina, that is called transvaginal probe, they are safe. Okay, the next thing is uterus is soft and non-tender. The presenting fetal part is high or displaced. So basically what happens that in placenta previa, the uterus especially is very soft, especially is non-tender, and the fetal part is basically high or displaced, and the fetal heart rate is usually normal. Shock or anemia correspond to degree of apparent blood loss. What happens that as there is some degree of blood loss, so the patient may suffer from shock if is sudden hemorrhage, sudden so much gush of blood is coming, or may patient can have anemia. Okay, now the complications are also very important to remember. So there can be fetal complications as well as the maternal complications. Okay, let's talk about the fetal complications. There can be perinatal mortality, but it is low. That's still higher than with a normal pregnancy. Okay, they are saying that around the delivery, around that time, the perinatal mortality of the fetus is a little bit, is not very high, but high as compared to a normal pregnancy. The prematurity, of course, the fetus can go into preterm labor and there can be a premature babies. Okay, and bleeding often dictates early cesarean delivery. Okay, So cesarean delivery can be the final resort if the bleeding is not stopping and we have no other way, and the vaginal bleeding is extremely dangerous. Now the intrauterine hypoxia can occur because intrauterine hypoxia can occur because the fetus is not getting enough oxygen supply, enough blood supply. They can be acute or IUGR. Okay, there can be fetal malpresentation. The fetus is not having the normal presentation or lie. There can be abnormality in the fetus presentation. There can be preterm premature rupture of membranes. Okay, so there can be preterm premature rupture of membranes. There is a risk of fetal blood loss from placenta, especially if incised during cesarean delivery. So the placenta can have fetal blood loss, especially if incised during cesarean delivery. The next thing very important is maternal complications. So there can be maternal mortality but is less than 1%. Hemorrhage and hypovolemic shock can happen because the mother because the bleeding is happening, so the mother can go into hypovolemic shock, and as a result patient can get anemia. There can be renal failure, there can be pituitary necrosis. Okay, the postpartum pituitary necrosis is known as Sheehan syndrome that can happen as a complication of placenta previa, placenta accreta, especially if the previous uterine surgery or anterior placenta. So therefore, what happens that in if there is previous uterine scar, previous uterine surgery, or an anterior placenta previa, and hysterectomy, that can be a complication of placenta previa investigations. First of all, we have to perform the transvaginal ultrasound that is more accurate. So always remember, not the transabdominal, transvaginal. That is more accurate than transabdominal ultrasound at diagnosing placenta previa at any gestational age. Number two, spontaneous resolution is likely with increasing uterine distension if the placenta covers internal loss by less than 20 millimeter at 20-week gestation. So, if the placenta is covering the internal os but is not too much, and if the placenta covers internal os by less than 20 millimeter and happens at 20 week of gestation, transvaginal ultrasound should be repeated in T3 as increased distance from the cervix is likely. So what can happen that trans cervical ultrasound is there, sorry, transvaginal ultrasound is there, trans abdominal ultrasound is there, and nothing. Important thing is okay, transvaginal ultrasound should be repeated in the third trimester. So transvaginal is more accurate compared to the trans abdominal ultrasound. Okay. Now, spontaneously, it will the condition will resolve with increasing if the uterus is getting bigger and bigger, and placenta covers internal loss by less than 20 millimeter. Not too much covering the os, just less than 20 millimeters. Okay. Now the management, the goal. The goal of management is keep pregnancy intrauterine until the risk of continuing pregnancy outweighs the risk of preterm delivery. Okay. So we have to make sure that it is we have to take special precautions during this pregnancy. Okay, and we have to make sure that the continuing pregnancy outweighs the risk of preterm delivery. Sometimes if there is no other option, then we can opt for preterm delivery as well. But if the risk of continuing pregnancy is more, then we have to opt for preterm labor as well. Stabilize and monitor the mom. Okay, all right, how we are going to stabilize the mother? We have to place large bore IV cannula, and we have to replace the volumes, and we have to give oxygen if the blood pressure is low. So we have to stabilize the mother by providing a large bore IV cannula, and we have to replace the fluid volumes as there are ongoing blood losses, so volume loss is there. Therefore we have to replace the volume, and also we have to supply oxygen if the blood pressure is getting low. Then maternal monitoring, that we have to check all the vitals, we have to check urine output of the mother, we have to check for blood loss, we have to look for the blood work. Okay, so we have to look for all the vitals: pulse, blood pressure, temperature, respiratory rate, oxygen saturation of the mother. Along with that, we have to look for the urine output of the mother. We have to look for any blood loss. We have to look for blood work, and blood work basically includes hematocrit, CBC, PTA, PTT, INR, fibrinogen, FDP, and typing and cross match. Okay, so what happens that maternal monitoring basically requires checking all the vitals, checking the urine output, checking the degree of blood loss. Either we have to do the complete blood work including hematocrit, CBC, PTA, PTT, INR, all the fibrin degradation products, fibrinogen, type and cross match the blood. Okay, and then we have extended fetal monitoring, we have electronic fetal monitoring, we have the special equipments for fetal monitoring, then ultrasound is also very important. Then the fetal and maternal conditions permit determine fetal viability. Okay, we have to make sure the fetus, there's nothing harm to the fetus has been done and the fetus is alive and viable. We have to look for the exact gestational age and placenta location. Where exactly is the placenta? Okay. Now the ROGAM if the patient is Rh negative. Remember, the ROGAM injection especially is given to Rh negative mother, and flow cytometry and KB test methods determine extent of fetal-maternal transfusion, and this helps to administer ROGAM at adequate dose. So we have to do some other special tests like KB test or the flow cytometry. These are basically done to make sure that we give the right dose of the ROGAM injection, and this is basically determine the extent of fetal-maternal transfusion or the hemorrhage. Okay, fetal-maternal hemorrhage and transfusion. And so at less than 37 weeks gestation, and if there is minimal bleeding, what are we are going to do? If the patient comes to you and the gestation age is less than 37 weeks, yeah, means it's preterm, and the bleeding is also minimal, what we have to do? We have to do expectant management. All right, so what we are going to do in expectant management, we are going to admit the patient in the hospital. We are asking the patient to do limit her physical activity, do a lot of rest, no douches, going to use no douches, no enemas, no sexual intercourse, consider steroids for fetal lung maturity. Okay, and delivery when the fetus is mature or hemorrhage indicating maternal or fetal compromise. So we have to keep a close eye on the mother, and we are going to make sure that the delivery can happen only when the fetus is very mature or the hemorrhage is indicating maternal or fetal compromise. Okay, and the hemorrhage is indicating what? Fetal or maternal compromise. If there is more than or equal to 37 weeks of gestation, we have to do delivery by cesarean. If less than 37 weeks of gestation, we have to do expectant management. If more than 37 weeks of gestation, we have to do delivery by cesarean delivery. Remember that. Okay, now the placental abruption is the second topic I am going to cover right now. The definition is the partial or total placental detachment, premature and caused by bleeding at the interface. So basically, whenever there is a bleeding happens at the interface of placenta, and there is basically partial detachment or total detachment, that is quite premature. So this is called placental abruption. What happens? It happens when it occurs at more than 20 weeks of gestation. Okay, if the pregnancy is more than 20 weeks, we call it placental abruption or placental detachment. And remember that if the pregnancy is less than 20 weeks of gestation, then we call it as abortion. Okay, next thing is placental abruption is the most common cause of DIC in pregnancy. Okay, complication of placental abruption is DIC. Okay, next thing is we need to know about the clinical features. Okay, now the clinical features of placental abruption is first of all classification. Whether it's total, where the fetal death is inevitable, means if the placenta is totally separated from its normal position and there is excessive bleeding is happening. So what is going to do? What is the consequence? Definitely there can be fetal demise, and they can be compared with the partial detachment. Okay, external, revealed, or apparent. So blood dissects toward downward towards cervix. Okay, there can be revealed hemorrhage, means evident hemorrhage, or external hemorrhage in which the blood that is dissecting to downward towards cervix, because placenta, from placenta the blood is oozing and is going down towards cervix, and we can see it's coming from the cervical os. Now the next thing is internal, concealed, or occult. Occult is hidden. Okay, so concealed means hidden, occult means hidden hemorrhage. And the blood dissects in 20% of the cases, blood dissects upward toward fetus. Okay, so blood is basically going upwards towards fetus and may or may not present with bleeding. Okay, so bleeding is not the only criteria for placental abruption. Sometimes there can be concealed hemorrhage where there is no visible bleeding, but the hemorrhage is there. Okay, and sometimes or most of the time they are saying this is mixed, means both things can happen. Either is concealed hemorrhage, hidden hemorrhage, or either is evident or revealed hemorrhage. Now, presentation usually painful. Always 80% of the cases this condition is very painful, and the vaginal bleeding not always present if abruption is concealed, as I already mentioned. Uterine tenderness, of course, when they are going to touch or examine the uterus, it will be extremely painful. Uterine contractions or hypertonus is going to happen, and the uterus is contracting really hard, and there is increase in the tone is increased, so the lack of relaxation between contractions can happen. Then there can be sudden pain. Pain may be sudden in onset, constant, localized to lower back and uterus. Okay, so what can happen that there can be symptoms like shock or anemia out of proportion to apparent blood loss. As we already know, the difference between placenta previa and abruptio placentae is this pain. A placenta previa is painless, abruptio placentae is extremely painful condition. Always remember, okay? And there will be sudden onset of severe pain, there will be constant pain, and especially localized to lower back and uterus. Okay, and the uterus is also contracting really hard, there is increased tone of the uterus, and the patient because of excessive bleeding can go in shock or anemia. Okay, and there can be fetal distress as well, and as a result of that fetal demise can happen. Okay, and there can be bloody amniotic fluid. Bloody amniotic fluid means because of the hemorrhage. Okay, and the fetal presentation is typically normal, but all these things can happen. And there can be coagulopathy. That's why it was mentioned that, as I already we saw the clinical pearl here, that the most common cause of DIC in pregnancy is placental abruption. Okay, so coagulopathy can lead to basically what? D, I, and C. Okay. Now, complications of this condition, blood sugar placental. First, there can be fetal complications. We already know there is a chance of mortality, there is chance of prematurity and hypoxia. And the maternal complications, again, the maternal mortality, DIC, acute renal failure, anemia, hemorrhagic shock, postpartum pituitary necrosis, or amniotic fluid embolism. Okay, all these things are very important when you're talking about this condition. Okay, investigations that we need to perform is basically a clinical diagnosis is made. Ultrasound not sensitive for diagnosing abruption. Always remember, the diagnosis is made clinically. Okay, ultrasound is not a sensitive indicator for diagnosing abruptio placentae. So KB test, as we already saw, that this is to quantify fetal cells in the maternal circulation. So extent of fetal maternal hemorrhage, we can be checked with the help of this KB test. Now, the management of abruption placenta is maternal stabilization, the first and the foremost thing. We are going to stabilize the mother with the help of a large bore IV cannula. We are going to give IV fluids to the mom. We are going to give oxygen if the blood pressure is getting low. We are also going to do monitoring of all the vital signs, the urine output, the blood loss, the blood work, same as placenta previa. Also, we are going to do the fetal monitoring. Also, we are going to make sure the blood products are available like RBCs, platelets, cryoprecipitates because of DIC risk. Okay, blood products should be available. RBCs should be available, platelets should be available, or cryoprecipitate FFP should be available. Now, ROGAM. ROGAM if patient is RH negative. What is ROGAM? ROGAM is basically injection that is always given to those females who are RH negative. So, we have to determine how much ROGAM dose is going to be given. So, we have to do the flow cytometry and KB test to assess dosing of roga may confirm abruption. Okay, so there are two tests which are known as the flow cytometry and basically the KB test to assess dosing of roga. To assess dosing of roga may confirm abruption, not diagnostic. Okay, now abruption that can happen without fetal or maternal compromise, that is known as mild abruption. Okay, abruption, yes, I mean to say that abruption that can happen without fetal or maternal compromise, that is known as mild abruption. If it happens less than 37 weeks of gestation, we need to use serial hemoglobin to assess concealed bleeding, hidden bleeding, deliver when fetus is mature or when hemorrhage dictates. So if less than 37 weeks, make sure we have to check the hemoglobin. We have to make sure that the delivery, if when we are going to deliver the fetus, or the fetus should be mature enough, or if the bleeding is too much, then we have to do the premature delivery as well, preterm delivery as well. If it's more than equal to 37 weeks, stabilize and deliver. Of course, we have to stabilize the mom, stabilize the fetus, and delivery is the final or definitive management. Okay, now the abruption with fetal maternal compromise. Okay, if there's a compromise, the fetus and the mother both happen, then we have to do hydrate and restore blood loss, correct coagulation, defective presence. So if there's any coagulation problem, we need to correct that. We have to hydrate and restore the blood loss. Okay, we have to give enough fluids and restore the blood loss. Vaginal delivery if no contraindication and no evidence of fetal or maternal distress. So we have to opt for vaginal delivery if there are no contraindications and no evidence of fetal or maternal distress. Cesarean delivery if live fetus and fetal or maternal distress develops with fluid or blood replacement. Labor fails to progress or if vaginal delivery otherwise is contraindicated. So, abruption that can happen with fetal or maternal compromise. So, what will happen? What we are going to see? We are going to see either we have to hydrate, we have to give enough fluids to the patient, the mom, we have to restore the blood loss, we have to prevent the patient to go in DIC. Okay, we have to correct the coagulation abnormalities. Okay, and then we have to do the vaginal delivery if no contraindication and no evidence of fetal or maternal distress. Okay, we have to opt for vaginal delivery if we think the fetus and maternals are doing great, so we have to do vaginal delivery. But cesarean delivery if the live fetus and fetal maternal distress develops with fluid or blood replacement. So if the fetus is in distress, if the mother is in distress and labor fails to progress, or if vaginal delivery is contraindicated, definitely the only option we are left with is cesarean delivery. Now, the third topic I'm going to cover right now in the OBS chapter is Vasa previa. So here you can see picture of Vasa previa. What is going to happen here that the fetal vessels are reaching the cervical os. Okay, let's see. What happens in Vasa previa? Unprotected fetal vessels pass over the cervical os associated with developmental insertion of cord into the membranes of placenta or accessory lobe. So fetal vessels are going to reach the cervical os because of the insertion of the umbilical cord into placenta or accessory lobe of placenta. So basically what happens, the fetal vessels are basically covering the cervical os. This is known as vasa previa. Vasa means vessels, previa is the same like covering the os. So placenta is covering the os, vasa previa fetal vessels are covering the cervical os. So what are the clinical features? There will be painless vaginal bleeding just like placenta previa, and a significant fetal distress can be there. There can be tachycardia, bradyarrhythmia in a sinusoidal pattern. So what will going to happen? There will be tachycardia, increased heart rate, and bradyarrhythmia. So either increased heart rate or low heart rate, and that can happen in a sinusoidal pattern. If undiagnosed, 50% perinatal mortality. Perinatal mortality is very high with that, increasing to 75%. If membranes rupture, most infants die of exsanguination. Okay, so what is going to happen that if the membranes rupture, definitely the fetus is going to die. Okay, if membranes, because these are the fetal blood vessels, so if the membranes rupture, then most infants die of exsanguination. If diagnosed antenatally on ultrasound without labor or symptoms, okay, if diagnosed already on ultrasound without any sign and symptoms, then definitely survival is very high. So, what investigations we are going to perform for this condition? One very important test is called the APT test, that is sodium hydroxide mixed with the blood. So, what we are going to do? We are going to do that sodium hydroxide is mixed with the blood, can be done immediately to determine if the source of bleeding is fetal or maternal. Okay, so what we are going to do? APT test. Remember, a test that is done to investigate this condition is called APT test. APT test, okay, in which we are going to mix sodium hydroxide with the blood. It can be done immediately to determine if the source of bleeding is fetal or maternal. So basically we want to rule out if the source of bleeding is fetal or maternal. We have to do this APT test, or sodium hydroxide is mixed with the blood. Okay, so what happens that if the source of bleeding is fetal, then supernatant turns pink. Supernatant means the thing turns pink, or maternal supernatant turns yellow. So the color will turn pink in the case of if the source of bleeding is fetal, and it will turn yellow if the source of bleeding is maternal. Write stain on the blood smear and look for nucleated RBC. So there is a specific strain called Wright stain that is present on the blood smear, and look for nucleated RBCs in the cord, not maternal blood. Okay, so we are going to look for nucleated RBCs, okay, in the cord, not in the maternal blood. So right stain and look for nucleated RBC. Right stain and look for nucleated RBCs in the maternal, in the cord, fetal cord, not maternal blood. Management is basically planned cesarean delivery, that is basically done at 35 to 36 weeks of gestation, or if there is a bleeding, there is emergency cesarean delivery. Since bleeding is from the fetus, a small amount of blood loss can have catastrophic consequences. So basically this condition should always be managed with planned cesarean delivery early, 35-36 weeks, and if there is bleeding, there can be emergency cesarean delivery. So the bleeding is even from the fetus, especially, so small amount can have catastrophic, or we don't want to lose the fetus. That's why we have to take it very serious, and even if there's a small amount of bleeding, we have to do emergency cesarean delivery to get rid of this condition. So I am going to end my session for now. Hope you are getting benefit from this session, and if these sessions are of any benefit to you, please like, subscribe, and share. Thanks so much for all your support. Have a nice rest of the day. Take care. Bye, guys.